Thank you, Mr. Chairman, and good afternoon, everyone. First of all, I'd like to thank the organizers of this meeting for inviting me here this afternoon. The title of my presentation is Aortohepatic Conduit in RE-LT, Bridging Innovation and Surgical Precision. The aortohepatic conduit placement is a bypass surgery in which the conduit is passed through the transverse mesh colon via the retrogastric plane to connect the infrarenal aorta with the hepatic hilum in selected LT recipients with inadequate inflow arteries. For most transplant and vascular surgeons, it is considered a technically simple procedure. I have been doing the aortohepatic conduit placement for liver transplantation at Assam Medical Center for about 20 years. But I don't think there has been any particular technical development regarding surgery during this period. I have no disclosures for this presentation. I will proceed in the following order: introduction, surgical techniques, technical considerations, Assam Medical Center experience, and finally a summary. As I am a vascular surgeon and not an expert in liver transplantation, all decisions related to the overall transplantation process, including indications, type of arterialization, and post-op management, are made by transplant surgeons. Therefore, I will only talk about the technical aspects of the aortohepatic conduit placement during liver transplantation. Let me start by providing some background on the role of aortohepatic conduit placement during liver transplantation. The standard arterial reconstruction during liver transplantation, end-to-end graft hepatic artery to recipient hepatic artery, is performed in around 90% of cases. When this reconstruction is not feasible, alternative sites in the recipient to anastomose to the graft artery include the splenic artery, the celiac trunk, the supraceliac and infrarenal aorta, and so on. All healthy arteries close to the liver can be used as inflow arteries for liver transplantation. In this presentation, I will talk about the use of the infrarenal aorta as an inflow artery during liver transplantation at Assam Medical Center. Although there is considerable debate about the safety and indications for aortohepatic conduits, their placement remains an important alternative in liver transplantation. This is particularly relevant today as increasingly older patients are being added to health waiting lists, and the salvage or repeat transplantations are more frequently performed in selected patients. This technique is often used in complex cases, particularly in recipients at a high risk for arterial thrombosis, those with severe thrombotic disease, those with a history of liver biliary tract surgery, or those undergoing transplantation, especially when a standard arterial anastomosis between the hepatic artery of the graft and that of the recipient cannot provide adequate inflow. In the event of inadequate inflow in the recipient's hepatic artery, an arterial allograft recovered from the same donor and then interposed between the recipient aorta and the graft hepatic artery is usually used. Although placing an aortohepatic conduit can be life-saving for many LT recipients, some authors have argued that its use should be strictly limited in adult primary liver transplantation because of high complication rates and reduced graft survival. In adult primary liver transplantation, Shibi and colleagues reported the placement of an aortohepatic conduit was linked to a higher risk of graft loss for up to 5 years after liver transplantation, mainly due to hepatic artery thrombosis and infectional sepsis. In comparison with adults with standard arterialization, They showed significantly higher risks of hepatic artery thrombosis, ischemic cholangiopathy, and low 5-year graft survival rate in adults with a conduit. I will talk about surgical techniques of aortohepatic conduit in liver transplantation at Assam Medical Center. After completing the portal vein and hepatic vein anastomosis, we place an aortohepatic conduit between the infrarenal aorta and the hepatic hilum, passing it through the transverse mesocolon and along the retrogastric plane. The conduit is fashioned from the donor aortoiliac arterial segment, obtaining during liver procurement and preserved in preservation solution. For the proximal anastomosis between the aortoiliac arterial segment and the infrarenal aorta, we use a 5-0 running plain suture. To create a wide vessel and jet the distal anastomosis between the vascular conduit and the graft hepatic artery, we make a longitudinal incision in the graft hepatic artery and the use of 5-0 or 6-0 running plain suture. This approach also helps reduce size discrepancies between the donor hepatic artery and the conduit. In our institution, post-surveillance protocol is similar to that of conventional living donor or deceased donor liver transplantation recipients with standard arterialization. The patency of arterial anastomosis is assessed serially with Doppler ultrasonography. Doppler ultrasonography is performed daily in the first week and on a weekly basis during the hospital stay. After discharge, Doppler ultrasonography is indicated whenever patients show elevated liver enzyme levels or signs of hepatic dysfunction. If there is a clinical suspicion of compromised arterial flow, computed tomography or hepatic angiography is performed to further delineate the arterial inflow to the liver according to each patient's condition. There are several important technical considerations when placing an aortohepatic conduit in liver transplantation. Although these technical tips are fundamental concepts in vascular anastomosis, the following highlight key steps that can help optimize surgical outcomes and reduce the risk of complications. As a precautionary step, the placement of a single vessel loop encircling the aorta just proximal to the aortic arteriotomy is recommended. This facilitates prompt control of significant hemorrhage if the aortic vascular clamp is inadvertently released. For secure proximal anastomosis, partial clamping of the aorta is technically easier than total clamping, and it also helps prevent bleeding from lumbar arteries and preserve distal perfusion during aortic anastomosis. In addition, after creating the aortic arteriotomy, tacking suture should be kept in place in the operator side to ensure a secure aortic anastomosis with proper intima-to-intima approximation. After completing the aortic anastomosis and routing the vascular conduit, it is critical to ensure that the vascular conduit is not twisted. Before performing the anastomosis to the graft hepatic artery, it is important to confirm that the vascular graft is free of kinks, which can be done by checking for immediate brisk breathing upon release of the aortic clamp. The gastroduodenal artery should remain untied until the patency of the aortohepatic conduit has been confirmed. From the perspective of a vascular surgeon, maintaining hepatic artery patency and optimal hepatic blood flow requires three things: adequate arterial inflow in the recipient, a properly oriented anastomosis with precise intima-to-intima alignment, and a relatively low resistance outflow through a healthy liver graft. Previously, we reported our results of 25 adult liver transplantation recipients with aortohepatic conduit placement. During the median follow-up period of 37 months, all conduits remain patent with no cases of hepatic artery thrombosis or stenosis. However, recently we updated our long-term results of aortohepatic conduit placement during deceased donor liver transplantation. Among the 877 deceased donor liver transplantation recipients, 30 underwent aortohepatic conduit placement due to an inadequate recipient hepatic artery. Over a mean follow-up period of 60 months, we observed relatively higher rates of stenosis, 18.4%, or occlusion, 10.5%. Therefore, in our conclusion, the use of an aortohepatic conduit should be strictly limited to carefully selected cases. Possible causes for the reduced long-term patency include the size discrepancy between the donor hepatic artery and the aortoiliac vascular conduit, as well as the long vascular conduit between the infrarenal aorta and donor hepatic artery. According to Poiseuille relationship, vascular resistance increases in proportion to the conduit length and decreases with the pulse power of the vessel diameter. Thus, longer diameter improves patency, whereas the longer conduit lowers it. Finally, long-term gradual degeneration and deterioration of the vascular conduit could be a possible cause for the reduced long-term patency. Despite the use of immunosuppressants, this is because of the susceptibility to chronic rejection, which can result in arterial degeneration and deterioration. In summary, placement of an aortohepatic conduit can provide a life-saving option for carefully selected recipients with inadequate inflow arteries during liver transplantation. With meticulous surgical technique and proactive surveillance, excellent long-term graft and patient survival rates are achievable. Thank you to my colleagues and liver transplantation team Asa Medical Center for their contributions. And I would like to express my special gratitude to my teacher, Professor Seung-Giri. Thank you for your attention.